Hello.
Hey, Tisha. Can you hear me okay?
I can. Can you hear me?
Yeah, I'm working at the hospital today because who knows what this Wi-Fi is going to do. So, um, I did want to ask, do you want to do like the introduction, kind of get us started because we never put a name next to it on the schedule. We just weren't sure if you wanted to just do that along with the other part.
That's fine with me.
Okay, just want to make sure before I sprung it on you.
Hey, Patty.
Hey, hey. I'm like talking on the phone, hanging up as I'm logging in. I'm like, please don't log me in yet. How's it
I
going?
know.
It's Friday.
Oh, it's going well. I've been in DC all week, so I'm a little
Oh,
discombobulated. Just got back yesterday.
what?
I'm the federal advocacy coordinator for Arkansas for psychology. So every year, APA flies us in for a
Uh-huh.
Hill visit. Um, so I was there visiting with our legislative
Okay.
teams. Yeah. There's actually gotta find the bill. I'm so like I said, I'm so discombobulated. There's actually legislation they're pushing for federally that increases the that's gonna ask Medicare to boost the reimbursement rates for behavioral health codes.
All right.
Um, yeah, so
That's a
we're
radical
advocating for that.
thing. How radical is
You
that
know,
to be paid for what we do? I mean,
Well,
yeah. So yeah, so I was gonna let everybody know about that a little bit. But it was fun. I took my child with me, so we had a good little mother-daughter trip. She's 16 now, so
woo,
um, I know
you're getting
we
old
had a
too.
blast. I am quite elderly. It feels that way some days.
Look, let's don't use words like elderly around here.
so
I'm feeling it.
teenage daughters accelerate the aging process.
They
So,
accelerate it.
I mean,
Yeah,
my
my daughter.
daughter was a good kid. Don't get me wrong, and I
Hmm.
love her, but the biggest birthday that I have celebrated in my life was her 20th because she's no longer a teenager, and so.
Yeah, I mean, I know mine is she's an exceptional kid, like gives me absolutely no problems whatsoever and is just a delight to be around. And again, it's still very stressful. So I just cannot imagine.
But it's different with girls than with boys. Boys, it's a matter of a level. You question, did you ever teach them anything, and is there a functioning level of intelligence in their head? Whereas with daughters, it's all emotional stuff. Like I'll never forget the one day when my wife
So
and
true.
who love each other and everything, but it was a mother-daughter explosion. I don't know what it was. And then 10 minutes after it was over with, my daughter comes downstairs and goes, I'm going to Target. Do you want to go? And my wife says, sure. Two people that were just yelling at each other that I'm sitting there, I'm running for cover and the dogs are scared. And the next thing you know, they're in the car going to Target. And I'm just like, how does it,
Just had to get it out of their system.
it was over with,
Time to move on.
but that's,
All right.
those
Looks
are
like
fun
we
things
have.
looking back on. I just kind of,
Well, they say boys are easier. My daughter just turned 18 last weekend. I may or may not have had a minor meltdown. And then my little boy is turning 7 tomorrow. So there's a big, but he is 10 times more of a handful than she has ever been, even in her teenage years. So
And I gotta call
There's a
my
lot
mom
of
and apologize to her or something because yikes.
I do
Yes, you do.
regularly.
Yes, you
well,
do, millennial.
I just tell people that in all seriousness, teenagers are why some animals in the wild eat their young, because you just never know what to expect. You love them, you'll do anything for them, but you just like, who are you people and why are you taking all my money? I just like,
That's an accurate
That
description.
that individuation process. Well,
I'm
looks
just
like we've got several people on. Do we have any other people that we're expecting that we should wait on before we get started?
You can go ahead and get started for people's time.
Okay. I'm all about efficient use of our time. So, welcome everyone to our community stakeholder group meeting this day on Friday, June the 14th. Really appreciate everyone coming today, and I'm excited to hear about different things that are happening around the state, and also hope that we can, bring up any questions or concerns or issues that anybody's having, and we can be supports to one another on this integrated care journey in Arkansas. Are there, I don't know, do we have any updates or announcements that I'm not aware of that we should bring up at this point today, Caitlin?
Not that I know of. I know Dr. Gibson will share a little bit about the conference they just had, and I'll talk about the training we just had. That's kind of our update. So I don't think we're missing anything.
Okay. I will. I was saying this a little bit before everybody got on, but I will give a little bit of kind of a federal slash national. I don't know if it's an announcement or an update, but as some of you may know, I am the federal advocacy coordinator for Arkansas for the American Psychological Association. So basically, what that is the American Psychological Association has a one or more people in every state that they kind of see as a liaison between the state, what's going on state wise in the legislative world, and what's going on in the federal legislative world. And really, it's a psychological association, so it's an association of psychologists. So really, what's happening in the mental health slash profession of psychology world. And I went to their annual fly-in yesterday. This week, I just got back from DC yesterday. So this is a Monday and a Friday for me. So I'm a little disoriented today. But one of the things I wanted to say is I met with three of our representatives' offices on Tuesday. I met with Senator Bozeman's office, Senator Cotton's office, and Representative Hill's office. And one of the pieces of legislation that we were telling them about and hoping that they would co-sponsor is called the Complete Care Act. It's been introduced in the House and the Senate. House Bill 5819 and Senate Bill 1378. And really, it does three things. It asks for CMS to provide technical assistance to primary care practices that are adopting integrated care. This bill is model agnostic, so it acknowledges the importance of both the PCBH, primary care behavioral health model, and the collaborative care model. And so it asks that CMS develop and provide technical assistance, so nationally to primary care teams. It also asks to boost the Medicare reimbursement rate for the next 3 years. So to boost it at 75%. So for at 175% for 2025, 150 at 2026, and 125 at 2027. Those are the Medicare billing codes. So the CoCM codes plus the more generic integrated care codes. And really, as we all know, that is to help boost and encourage the adoption of these codes, so that we all know things cost more when we implement them at the beginning, and so allow for more higher reimbursement rates. And also, if we think about with like our private insurances and Medicaid, a lot of times their payment is based on the CMS scale. And so if CMS boosts their reimbursement, the hope would be that other payers would also do that. So again, it's a temporary boost to help with implementation. And the other requirement is require CMS to establish quality measurement reporting requirements within existing Medicare alternative payment models. So again, to start establishing quality measures for more the other types of payment models besides fee for service. So that is something that is in the works, something the American Psychological Association is pushing for. I hope that if your profession, be it counseling or social work or psychiatry or the medical association, that you would also encourage your guilds to support this. And I don't know if it says to establish quality measures. So I think that it's more about research around quality measures than it is saying in the bill, these are the quality measures. And I know I can speak for the American Psychological Association. They have a very active and wonderful lobbying wing. I work really closely with them, and I'm sure that if this bill were to pass, then they would be working closely with CMS and the regulators to think about what those quality measures would be. So that's my update / announcement. Anybody have any questions or discussion around that?
Great job, Tisha.
Thank you. It was very exciting. I will say I've met with our legislative offices several times over the last few years. The staffers are really quite wonderful people and really nice to meet with and to talk to. And the staffers that are they take on the health related legislation and really kind of advocate for things. They've always been really open to things like this and mental health. So it's not quite as adversarial as some people might imagine that it is on Capitol Hill. So it was nice to get to talk with them. All right. So that is my update on that. Any other announcements or updates that came to mind as I was talking? The only other thing I'll say is that when I was on this call or on this trip, met with a really great expert in billing and coding in behavioral health. His name is Stephen Gillespie. He's actually I think he's from Arkansas. I know he did all his schooling in Arkansas. His brother lives in Arkansas and is a professor at UCA, but he is an expert in billing and coding. And I contacted Teresa and Amanda, and Kim was involved in those emails in thinking through maybe bringing him to talk to us at UAMS and our partners in the federally qualified health centers and help us really, and also with DHS and the state to really educate us on what the codes and the billing codes are that are established, how other states are doing things, and to really think through how we can make this a sustainable program. So he's very open to coming to Arkansas. He went to school at Hendrix, I think, and would love to come and visit. I think he has a son who lives in Fayetteville. So that was another thing that I was working on while I was in DC. I was like, Steven, you need to come visit us. He's really great.
Hey, Tisha, this is
Hmm.
Patty. Hi, sorry, I'm been sick all week, so I'm going to stay off camera to spare you all my um, dark circles. Sorry about that. Um, hey, I really appreciate that update, and I don't know if this fits in kind of around the advocacy part, but in your neighboring state in Missouri, and I'm representing Mercy, where we also are delivering collaborative care across the health system there. But in Missouri, through a lot of advocacy work, we were just able to get the collaborative care codes adopted onto the Medicaid fee schedule. And I don't know if you all are aware. Yeah, we were really excited. And that took a couple of years of, digging in with legislators in the Medicaid office. But I just wanted to share that for what it's worth, and don't know if there's any now, how we sort of share the tactics around that. Might be valuable back and forth, honestly, to share how states are getting this across the finish line. But I just wanted to make sure you guys kind of had that awareness.
Yes, thank you for that. And I think that's really helpful too for our partners at DHS and, partners across the state. I mean, the more I think our neighboring states
Yeah,
do this and the ones that are kind of more have similar populations
right.
and, ways of doing things, I think that's just a great way to learn.
Yeah,
And
agree. Oklahoma also, with their transformation, their Medicaid transformation work, and that the codes are live there as well in Oklahoma. So that may be a asset for as the work continues in Arkansas under your guys' leadership, which is fantastic. So thank you.
thank you. All right. Last call for updates and announcements. Okay. I will do a brief. Oh, I'm supposed to do the executive committee report. I was not at the executive committee. Um, I was in DC. Caitlin, do you have anybody here have any updates from the executive committee
I'm gonna say I
meeting?
was not there either. I don't know. Was Dr. Gibson there? I don't want to put you on the spot if you don't have anything prepared, but I didn't know you weren't there, Tisha. I'm sorry.
Well, I was there. I do not have my notes. A lot did happen. So I can't, but what I'll say is that that group continues to meet and move forward with, I know David is with the state and they're having to answer to SAMHSA's requirements for the reporting and all the budgetary pieces. The FQHCs now have their paperwork and ABN does too as well to kind of, it's taken almost the whole year to get the streamlining for the reimbursements to flow. So I think, and David may speak to some of this, but so working out a lot of the details of the grants. There's been discussions around the registries and what the different groups are trying to do. So we're getting some good support on that. Tisha, they did announce that UAMS has some hiring that y'all have been working on for a while, and hiring is one of the big startup costs to implementing CoCM across the nation. So, finding people to hire in terms of psychiatrists as well as case managers is a challenge, but you all at UAMS apparently are having some success now that you might have hired 2 BHCMs.
Yes, as of I think it was Wednesday, we have two that have signed their letters of agreement. So then they are supposed to start July 8th. And I am thrilled. We did have a lot of struggles on the side of HR, and because these are new types of positions, they don't really fit neatly in any job category. So we had a lot of back and forth, especially because we are trying to hire bachelor's level providers because it's so hard to hire master's level providers, especially at the rates that we pay. But we do have two amazing bachelor's level people who will be joining us in July. One of them, she's a community health worker. She's got her community health worker certifications and is just a go-getter. And the other one has a bachelor's in social work, has worked in a lot of different places, has a really great military experience, and she's I think going to be a great team member. So we're really excited about them.
Another
And that was
update.
my update too.
Yeah. Another update at the next executive committee meeting, we'll be reviewing part of the grant is to create a durable resource for vetted CoCM resources. And that's being housed on the ABIN website. And so I put the link in there. And so we'll be reviewing, updating this website and then reviewing it at the next executive committee meeting in July. So there's information on there already, including webinar recordings from some of the trainings, and some resources, and as well as recordings of all of these stakeholder meetings. It has been decided that this stakeholder group, even though we have been meeting, I guess in October will be 2 years, it is being established as part of the grant as the public stakeholders meeting, which is required by the grant. So this will be persisting, and everyone is invited, and it's a place for to disseminate information to the state as well as to bring in information to make the grant more successful and implementation to be successful at the beginning here with the FQHCs and UAMS, but then also to be able to make it a sustainable model across the state. So I think that's an important piece. So things are moving along slowly, but I think it's now getting some traction and momentum.
Yes.
So David, yeah.
Just say the last kind of announcement from us is my plan is, as we are kind of going through this hiring and training and onboarding process, I'm going to be collecting, like, I'm going to get our job description in a way that is helpful and the way that we actually want it to be. It went through several iterations as we were going through this hiring process, like onboarding documents, training, things like that. So that will be available as our other partners are going on this journey. So that's all I have from UAMS. Anything else, Patty? So our next update is from DHS. It looks like maybe David is here.
Yes, I am.
Hi.
I don't have too much to add to what has already been discussed. SAMHSA is still very slowly going through what we sent them. And I want to thank Teresa and her team that SAMHSA for the third time has rejected the patient participation protections. And so in a very short time frame that they gave us, Teresa and her team was able to get what SAMHSA requested. They had some very specific things that they were looking for. I think they were really focused on protecting youth, elderly, and like the intellectually disabled when they come into collaborative care. What will we put in place to make sure that they understand what's going on and are able to participate? So they, at least this time around, they did give us very specific things that they wanted. So hopefully this will be the last time we'll have to deal with the participation. So.
Great. Thanks, David, for all your work on this. I know that these grants can become quite tedious in these. And the details can be very, very stressful. And also want to shout out to Amanda Lunsford. She's here on the call, but she is who's working so closely with Teresa and the group at UAMS that's really kind of the hub of this. And I know she has put in many, many hours of work trying to organize us and get information and be a good communicator. So thank you so much, Amanda, for that.
I
Tisha,
do
I
appreciate you
don't
getting
know.
everything so fast when I need questions answered.
You're very welcome. I know how stressful it is, so I try to get it to you as quickly as I can. What do you say, Michael?
Tisha, I was just going to let everybody know, Amanda has done such a great job trying to get this group organized and meeting together. She has a documentary coming out called Herding Cats in Academic Medicine. And so she is, I cannot tell you how many times, I don't know how she does it, because really it's all the people, the schedules, and it's pretty phenomenal how she pulls it all together.
Well, thank you.
For sure. I would not want that job. The little bit that I try to do it, I'm like, David, was there anything else that you had?
No, nothing else.
Thank you for your update. Next on our schedule is the APA CoCM conference discussion with Patty.
I just wanted to share some info that was brought to us. Our Arkansas Psychiatric Society annual meeting was this June 1st, and we had Dr. Bill Beecroft from Michigan Blue Cross Blue Shield gave a presentation. The total conference was called Untangling the Weave of Addiction. And his presentation was very much about using collaborative care management with in addiction and substance use disorder. But he gave some good overview of what's happening in Michigan, especially with Michigan Blue Cross collaborative care management. And so I thought that's useful for us to see that actually Michigan Blue Cross Blue Shield, and these are their slides, that they have implemented CoCM now and have over 800 PCP or practitioners trained in CoCM in 239 practices. They have 1,270 practitioners who are getting value-based reimbursement, including OBGYN practices. They've done training in perinatal CoCM, SUD CoCM, and child and adolescent. So it kind of gives you an idea that there are states where this is working and in these special populations as well. And what Michigan Blue Cross was really looking at, why would they go to the trouble to implement a project? And it's the same needs that is happening everywhere. The difficulty with access to mental health. Most people are not getting treatment that they need. And that there is mental health treatment does work if people get it. So most people are in their primary care office, but the PCPs don't have adequate knowledge and resources themselves and have big wait times to get people into care. So CoCM is something that meets these needs and overcomes these barriers. And then Michigan Blue Cross is seeing it as a solution also to being population focused, measurement guided, and evidence-based, and finding that the evidence is showing CoCM is twice as effective of treating depression, anxiety than traditional care for mental health in primary care. And this is, Michigan Blue Cross reviewed the foundation study at impact, showing the cost savings over 4 years, the effectiveness, and they're seeing a lower annualized total healthcare cost savings of over $7,471. So they described their journey in Michigan Blue Cross of implementing CoCM. And it actually started with their patient-centered medical home model. They have a different name. I think it's PGIP, but they built their CoCM model on top of their patient-centered medical home. So once they got team-based care going, and then adding in MAT and addressing social determinants, then they're using the CoCM model as part of the behavioral health access. And this was an outline that shows, and some really good points here, that even though CoCM has been around for 40 years, there's over 100 evidence-based trials, including some randomized control studies. Scaling the model has really been difficult, and the barriers to integration have to do with payment models and difficulty in getting implementing. So they have added some financial incentives, and Patty Morrow, as you were talking about Medicaid, Michigan Medicaid is a payer, and they're finding that having all the payers on board so that when practices are spending the time and effort to implement the model, that they've got a good payer mix. So they're given their timeline of implementing their program. Really, they call it their co-care program, implemented in 2021. Then in 2021, or 2020, they started. 2021 expanded to pediatrics, OBGYN, and substance use. And what they do is they actually have an attestation program, and you see how they've got CoCM designation program. And so they're dealing with some of the same issues that we've had concern, I think legitimate concerns that I've heard Arkansas Medicaid say, is that there's a concern of people just using the codes, but not actually doing the model. And so Michigan Blue Cross actually has a fidelity standards. And so when programs are getting the compensation, they do have to, and they're declared CoCM designated program. That includes some training and then making sure that they're using all of the parts of the model. So that's something that really we might want to consider, and might want to especially take back to Arkansas Medicaid as they're thinking about how to make this work for the state. This is Michigan Blue Cross's. We see this triangle all the time, but just to remind, because I think people are confused about the fact that the reason it's set up this way is for professionals to work at the top of their level of training, so that the PCP is taking care of the patient. The psychiatric consultant, you can see the dotted line between the PCP and the psych consultant, is that they are not seeing the patient regularly. The PCP is billing for the service, whereas the behavioral health care manager is seeing the patient, talking to the patient, either virtually or in person, and that the registry is a huge piece. And I just went ahead and showed that to show that we aren't making up the model in Arkansas. It's the model across the country, and the Michigan Blue Cross has implemented it. So these are the results of their patients. This was from January to June 2023. And they're seeing the consistent outcomes that are in the other studies, showing that my pointer's not working. Oh, here it is. That PHQ-9 and depression in these 353 patients that were in it for those 6 months showed 59% show an improved PHQ-9. And this is showing the number of the scores going down at the end of that they started a baseline of 13 and with a mean decrease of 6.8. GAD scores measuring anxiety also going down at more than 54% were improved. And this is showing that actually remission data, and we've had a lot of controversy in the field about quality measures, and that's why I was asking you, Tisha, what quality measures, because one of the measures used to be treatment to remission, and but this is showing that with collaborative care management, they had 73% of the patients enrolled did get remission within 5 months, and at least almost 40% had a 50% drop in their scores. Same thing with anxiety, treating to remission. And one of the big pieces here that the CoCM model brings is that you're measuring, and that's the importance of the registry, that you need to be measuring what people's scores are. And this is, again, just summarizing some of their outcomes, and especially, you know, as a payer, Michigan Blue Cross, they are very interested in making sure not only making quality care available, but also taking care of their population, and it needs to have a good return on investment. And that's what they're seeing, is that they feel that their members are getting good care. So just to focus on Arkansas, I think I've said this different times, but Arkansas Blue Cross Blue Shield has the same approach and has been paying for the CoCM codes. And you can find the policy on this is the public website. If you go to it, look under providers, and you can look under payment policies and look up one of the codes, you'll be able to link right there on the policy. And the Arkansas Blue Cross policy is pretty much what CMS has. It's got the same criteria defined that fit in with that fidelity to the model that I think is going to be important as we continue to roll out the model. And this is just a picture of the ABN website. I put a link in so that as people are wanting to try to begin implementing the model, that we're going to have some resources there for you. So just wanted to share. Arkansas Psychiatric Society and the American Psychiatric Association are supportive of this and trying to help practices across the country to be able to increase access to mental health. And so it's good to see what's happening in other states. Patty Morrow, yes, I'll be glad to share these slides. Misty and Caitlin, I guess y'all are sending out the emails on this. So
Yeah, Misty is lead on that. She can send that out.
okay. Does anybody else have any questions about that piece? Sarah, do you want to say anything?
Hi, folks. I'm Sarah. I work at the University of Michigan on a team in the Department of Psychiatry called PRISM. So we've been working with Dr. Gibson, kind of been learning right along. The only thing I'll add is our team just received a relatively small grant in addition to our contract with Blue Cross Blue Shield of Michigan from the Blue Cross Blue Shield of Michigan Foundation to evaluate our technical assistance to practices implementing collaborative care that were in Dr. Beecroft's slides that Dr. Gibson just shared. And we're using collaborative care billing codes. So, our practice is actually using and billing the codes as our proxy measure of implementation, and then looking at factors associated with higher success in implementation. So officially, that project hasn't started yet. We're just kind of in the startup phase. It's intended to be a pilot. And then hopefully over time, we could look at other payers, for our projects in Michigan beyond just Blue Cross Blue Shield of Michigan. So in a year or two, we'll have our results hopefully to share about that.
Thank you for letting me call on you, Sarah.
Of course.
As part of my learning, I have audited the trainings that Sarah and Burns and University of Michigan PRISM have done. It's excellent training. And so it's given me a lot of knowledge as well as confidence in terms of what the model really is and that it can work.
Yeah, I'll say one more thing. So the trainings that were mentioned, are the base collaborative care training modules in perinatal and adolescent pediatric that were in the slides. That's our team that's delivering those. And we just launched our training on treating substance use in collaborative care settings, which is super exciting for me. We just delivered it for the first time a week or two ago for folks as part of the Blue Cross project in Michigan. Still waiting on the evaluation results for that to get feedback and see if we need to make adjustments, but lots of disorders can be treated in collaborative care.
Thanks very much. And I will say,
It's really
Sarah
exciting,
is a
Sarah.
great trainer herself. She is an excellent teacher. So,
Well, thank you. I appreciate it.
I was just gonna say, we had her, she presented for us back in April, and we got such good feedback from that presentation. That yes, it was fantastic.
If you have evaluation results, I'd love to kind of share that back to Dr. Music, my co-presenter as well, if you have those from the CEU process or the CME process.
Let me ask in my team and see.
Yeah.
The recording for that presentation is on the ABN website too.
Gotcha. Hold on. Let me see if I can ask with it.
That's all from me.
Thanks, Patty. That was always love to hear what's happening in other states, and I always learn from them. What do we have next?
We've got me, not to sound egotistical, but it is me next. No, it
You're
is me
next.
next. And I just wanted to share, we did one of our trainings as part of the objectives for ABIN and with the FQHCs. We started our 3-part training series with them in May, and it went really well. I was just going to share a couple of slides from it just to kind of let you guys know what we talked about and what we're planning to discuss come June 18th. Everybody see that? Okay. I'm going to be real honest. I'm just going to leave it here because it's easier for me to navigate. So, so Verna Little was the presenter. She's going to be doing the next 2 trainings as well for the FQHCs. And this was, like I said, part 1 of our 3-part series. We did a 3-hour training with the FQHCs on really kind of the foundation of CoCM, which I'm sure Verna Little is not, one, she's usually on these calls, and 2, she's not new to anyone on this call. She's a wealth of knowledge when it comes to CoCM. So she kind of started out everyone on the foundation of CoCM and kind of what you needed to know on that is just that it's kind of an all hands on deck approach. Everyone from front desk to the clinic manager to leadership to the provider in clinic need to be on board for this to work, which is something that we hear over and over again and often is a barrier for many health systems to implement this model. So she just kind of level setted with that. She did give some examples on where, like the impact study and all that where it did work. I did not include that slide just because we're kind of familiar with that. But she did talk about where it worked and then wanted to go over some myths with some of the FQHC employees, just talking about how, you hear from other people in health systems about how CoCM is brief treatment or it's a lower level of care or that it's not really therapy. You have to pick a model for it to work or a patient has to be on medication to be involved in a CoCM program. All of these things are myths. It is a type of therapy. You do not have to pick a model. In fact, I'll be really honest, I operated from a blended model for several years and it worked really well. And sometimes patients don't need to be on medication. Sometimes they just need some behavioral changes to help improve their health. So I thought it was really unique and very nice of her to talk a little bit about the myths that may be coming across some of the conversations that they're having. Another part of the training for Verna, I really liked this. It probably is a little bit too small to see, but we do have the recording on our website, which I'll talk about in just a second. But she gave this really concise graph here that just lines out the care approach and then everything underneath it and like coding, who's appropriate for this model depending on what their diagnosis is, whether or not focused brief interventions will help, or if they have a more complex health need. I think, these are all things that we talk about in this model, but it's really hard to map out for some people. And I think she did a really good job. I actually asked her for a copy of this. So hopefully she can send that to us. And this is something that we can send around to the group because I think she just did such a nice example of this. Like I said, I know it's kind of hard to see, but that is on the recording that we have. Let's see. She talked about the core principles of collaborative care, that it's, obviously evidence-based, patient-centered care. We do treatment to target, much like Dr. Gibson was just talking about with Michigan's program, and that it is short-term by design. As the first time that you meet with a patient, you're focusing on graduation. How are we going to make it functional for this patient? How do we get you to the highest level of functioning as possible? Kind of, talking about termination as soon as you start meeting with them. This, we just saw this from Dr. Gibson. She reintroduced this to the FQHCs. Their employees are pretty educated on CoCM. They're educated on integration, but we just felt like it was a good idea to start them kind of at a foundational explanation of CoCM. And then just treatment options that are within the model. So obviously we're using things like CBT and problem solving and DBT approaches and ACT. So there is what they call talk treatment. I don't love that that phrase, but there is therapy modalities obviously in the model. Some behavioral activation where they're teaching psychoeducation and teaching how to work that into your everyday schedule. Helping them with their medication and finding ways for them to take their medication easier. And then symptom monitoring. Obviously, we know an important part of the CoCM model is doing frequent check-ins with our patients and making sure that they are on track to reach their health goals. And I really appreciate her putting this in there because I feel like it gave a really real world look at the things that go on in this model. I think oftentimes until you get into it, you can only kind of have an eagle eye view. I thought this was a good way for her to explain. This is what actually goes. This is how the sausage is made. This is what we're doing behind those closed doors. And then she did just briefly common questions about like what does an intake look, especially if you're a behavioral health person coming from a traditional setting. Intake is going to look very, very, very different in CoCM. And she really cautioned the FQHCs to even use a word like intake, just so that the staff gets used to saying, you know, this is a brief model where you go in and you meet the patient where they're at. There does not need to be an entire biopsychosocial intake, and we can work off of what they're presenting. Just talked about very briefly about the consent aspect of CoCM. This is still a developing thing. I don't want to get bogged down here. I know this has a lot of different people weighing in on whether or not they need to have like written consent, where does that belong in the chart, that kind of stuff. And how do we tell the patient they're in collaborative care, and can you use telehealth for this model as well? And then finally, she did give an example of how it looks when it is successful. And I'm sure that you all heard from Verna, the 30-60-90 rule about how to set up how many patients you're seeing the first month, the second month, and the third month to be sustainable. Talking about the outcome, knowing what your quality metrics need to be, and then taking a population health approach and involving the entire care team in that. So this was a 3-hour training. I didn't want to re-give Verna's training. I just kind of wanted to give a brief overview of what the FQHCs were exposed to in May. She did very briefly with this training go over billing, but the FQHCs were hungry for it, and they put on their survey that they would really like to discuss billing and more in-depth explanation of care team roles during the next training. So that should be what is discussed on June 18th, which is our next episode of this training series. So we're really excited. Like I said, we did a survey. We got really good feedback on, you know, they felt confident now that they understand the information and the foundation of CoCM, and that where they feel a little bit shaky is just like the implementation of it and how are we going to pay for it. Valid questions for these FQHCs. So just wanted to share that objective is being worked on. We're getting really good feedback from it. We're excited, and Verna comes back and teaches again on the 18th. This one and the subsequent trainings are going to be available on our website. So while the live training is closed to the just the FQHCs, you are able to go to our ABIN website and watch those recordings. We did have 20-ish, give or take, employees from both FQHCs on at the time, and we've already seen forwarding of the training link sent out to more people. So we're really hoping that we can reach even more people within their health systems next week and then again in July. So good reaction to it, and you guys are welcome to listen into Verna because she's a wealth of knowledge. I'm sure we can still learn a whole lot from her. I'm gonna hand it back over to Tisha.
Thank you so much, Caitlin. I had added in there that the slide that you liked that had all the codes and stuff, that's we actually Verna created that as part of a talk that we did with C of HA. I think it was last year? I think it was last year. So I have that. I can get it to you. I have a copy of that slide.
Thank you.
It is incredibly helpful in
Very.
looking at our brains and like thinking about what we need. Um, and then also I wasn't able to attend the entire training, but I have just kind of had it on loop. And when I have time, I listen to Verna talk about this. And as someone who has been learning and studying and doing this for a long time now, it's she just does such a great job, and it really helps me to orient myself to be like, okay, this is what we need to be doing. This are she's just so knowledgeable. So I would encourage everyone to as someone who attended it and has done this for a long time, I'm still listening to it because she does such a great job of like explaining things and helping us to really think about real. She's very pragmatic and problem oriented. She's not it's not one of those theoretical talks that will make you take a nap.
Yeah.
She's very engaging and has great ideas. So I encourage everyone, especially anyone involved in this project. I'm going to really encourage even like Amanda and Teresa and Mike and the anyone involved in the project to listen to her talks, because I think it really helps us to understand like what in the world are we actually trying to do here, and why, and how cool it really is when it's actually implemented. All right. Is there anything else before we adjourn?
Yeah, I think it is my turn to end with all of the upcoming events and resources. And there's not a whole lot of new ones that we didn't share last month. And I will be putting open up my chat, the links to all of these in the chat. I will also be putting them in the notes that are sent out after the meeting. But of course, CFHA has their in-person conference in October in San Antonio. Their theme is 30 years of integration, innovating in the pursuit of healing. And which I think we mentioned last month. Also, I know Michael mentioned last month about the Arkansas Schizophrenia Conference that is being held in September at UAMS from 8 to 3. I didn't think we had a lot of details, but now we have a date and a time. So I'll go ahead and post that in there.
And you've got a conference registration. So
Yes, I
register
put that.
early, bring your friends.
Come one, come all.
That's right.
Thanks, Michael. We also, I think we mentioned this last month, but ASU is having their conference, their annual conference in DC in August. Put that in there. A new one that we have that we did not mention last month is the Arkansas Council for Behavioral Health. They're hosting their conference in Hot Springs also in August. That theme is reflecting on the past, imagining the future. Got a lot going on in August. What else do we have? It looks like that's pretty much for the in-person events. A couple of upcoming webinars. Or I guess just one. During ABIN's July webinar, we will be hosting digital solutions for integrated behavioral health. My mouse is not wanting to work here.
I think that's That's a young psychiatrist. I heard him
Yes,
at
Dr.
the
Scott Rittinger. I'm not sure quite how you
he
pronounce it, but
he was at the Mayo Integrated Care Conference live I went to in the fall. And, you know, it said digital solutions, and that's getting pretty boring to see. And we thought, well, he's going to just show us a lot of mental health apps. But he will be presenting some ways of thinking about how are we going to be using, you know, digital, all different types of solutions. So it's not going to be your same old, here's a list of apps. So we've had to wait a while to get him into our schedule, and I think you'll be pleased to hear him. That's July 11th.
yeah, I think he'll be touching on evaluating like the utility of specific digital tools and interventions within particular settings. So as Dr. Gibson said, he can make that topic as interesting, I guess, probably as you can. And then lastly, I know it's been mentioned several times throughout the meeting, but ABIN's website is always there with different resources and webinars, CoCM webinars for you guys to view. Oh, nope. I lied. One more thing. Caitlin wanted me to shamelessly plug our podcasts, which I think she mentioned last month, but they really are some great podcasts that they're not primarily focused on CoCM, but nonetheless, still some great information. You can also earn CEs, CMEs, whatever your profession may be. There's different links for each platform that you listen to. So I will send those out separately also, along with all of these in the minutes.
I did not pay her to say that. So just want to put that on there. And the reason I'm bringing, or I asked her to bring it up, is because we just posted 2 new episodes like this week on postpartum mental health and language and access to healthcare. So it's new up there, and like she said, you can get CEUs for it, and who doesn't need CEUs? So
Does anybody else have any events that they're aware of or that they want to share? All right, then. Tisha, I'll hand it back to you.
Great. Well, we are almost right on time. We've got 4 minutes. Is there anything that we have missed or things that we want to bring up before we adjourn?
Tisha, this is always a great meeting. I appreciate you and everybody else for the work you put into organizing it and the participation of everyone. You know, you go to some of these meetings and it's like, ugh, but whenever you come to this meeting, it's always good and interactive and informative. And that just doesn't happen. So it takes a lot of effort. So thank you for everybody for their work on this.
Well, thank you very much, Michael. I cannot take any credit for this because I just said I would help because Kim isn't here, but
Yeah, Tisha, but we were going to blame Tisha. You would be blamed if the meeting sucked, though.
It's true. Yeah.
So
I would give that to Caitlin and Misty too. So
thank you.
Following you, Misty and Caitlin, would not at all. No.
Yeah, no. I think it's the people. It's a great group, and we've got a really important cause that I think we all believe in. So it's
True.
nice. It's nice to be with kindred souls that are doing good work. So thanks everybody. I hope you have a good rest of your month. It is 100% summertime in Arkansas now. I think today it's going to be 97. So stay cool, everybody.
All righty. Thanks, y'all.
Thanks, guys.
Bye.
Appreciate it.
Bye.